This episode of the Senior Rehab Podcast is sponsored by the Academy of Geriatric Physical Therapy. AGPT's mission is to further your ability to provide best practice physical therapy and to advocate for optimal aging. One of their most popular articles published is Dale Avers' white paper on strength training for the older adult. You've likely heard us talk about this paper, but it is a fundamental piece of work that I highly encourage y'all to read. This paper covers proper dosage, how to set intensity, and how to get your patients strong. You can find this resource for free and much more over at geriatricspt.org/SRP. That's geriatricspt.org/SRP. Hit me.
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Hello, friends. Welcome to the Senior Rehab Podcast. This is your host, Dustin Jones. Today, we are going to talk about blood flow restriction training. This has been a pretty sexy topic in the world of physical therapy, not so much in geri-PT, but we're seeing a lot of its application and definitely in athletics, younger populations. But as we all know, most things that are good for young humans are also good for older humans. So we're going to talk about its application. So I went to a course, the BFR course with Owens Recovery Sciences. Johnny Owens is a PT that started that company. He was actually my first interview. So if you go all the way back to the beginning of this podcast, check that out. Johnny Owens' first interview is like 2.5 years ago or something along those lines when this episode publishes. But I've talked with him. I've talked with Kyle and Ben, who are two other faculty. Awesome guys. Had a great chat with them. And then I finally got to go to the course. And Zach Dunkle was the PT that taught the course. Today, what we're going to do, I'm going to play I did a Facebook Live kind of recap that night after I took the course, just to get some fresh thoughts, some critiques if I had any, but also, just what was really sticking on the forefront of my brain in terms of, takeaways. So I'm going to play that first, and then I was able to talk with Zach and ask him some of your all's questions in the Facebook group. So some more specific BFR questions that, concern us as geri-PTs, some pretty common questions that we come across, but very helpful. So Facebook Live, recap first, and then an interview with Zach Dunkle. All the links will be in the show notes to Zach's Twitter account and Owens Recovery Sciences. So let's do it. Hello, everybody. Saturday evening, watching the Celtics work the Milwaukee Bucks right now. I'm winding down, just kind of recapping the BFR course, the blood flow restriction training course with Owens Recovery Science. Zach Dunkle was the instructor. Awesome day. Got to just finally get my hands on that piece of equipment. Just really been following those guys for a long time. Johnny Owens was my first interview on the podcast, which is crazy, about 2.5 years ago or more than that. But it's been a topic that's been intriguing to me, and now I know why for sure after going through the course. So I've got all kinds of notes that I took today. I just want to kind of give some big things that were big takeaways for me. Tali, good evening. All right, so the first thing, I was definitely the only geriatric clinician there, the only hashtag geri-PT, if you will. Lots of athletic trainers. That course is pretty popular with that group, and some PTs as well, but definitely the outpatient ortho crowd. Like, I was definitely the black sheep in this course, but they welcomed me with open arms. But I found that interesting. It wasn't surprising, but I found it interesting. But what I really loved was that Zach has brought in a lot of the evidence of BFR's use with older adults. So yes, there's a lot of people that work with athletes that go to this course. But there's a lot of the evidence that definitely applies to the population that we serve. I don't know if Zach, was just trying because he knew I was going to ask a question or whatnot, but he just really spoke well to this piece of technology's use in older adults. And the research, y'all, is crazy. This is probably one of the most evidence-based courses I've been to. There's not a lot of guruism. There's not a lot of, in my personal experience or opinion, the amount of references for these slides are just ridiculous. And what's really cool is a lot of the research that's done with this technology. It's not necessarily physical therapy research. It's a lot of physicians. It's a lot of physiologists. It's this wide array of, people that are in healthcare in some way, shape, or form that are performing this research, seeing how blood flow restriction can impact people. So I just found that really refreshing. That it was just kind of this very objective view at this piece of technology and how we can leverage it. There's going to be bias in every course that you go to. Everyone's going to have their own personal opinion. They're going to preach their gospel. But I just felt like, oh yeah, the data's pretty clear. I can trust this. I should probably start to use some of this stuff. So yeah, the research was really impressive. Erica, good evening. All right, what else? So the big point of application that I want us to think about is that with blood flow restriction training, we can have significant gains in strength and hypertrophy with a very low load. So right now, for me as a home health clinician, I need to at least be above a 60% of a 1 rep max to challenge my patients and to promote some type of strength gain. 60% being on the low end of that. I definitely want to be higher. And so, I have to try and do that. But, that can be kind of difficult for a lot of our patients, especially in the presence of pain. Like, we can definitely work around it, and we can do that with a lot of our patients. But it would be nice if I could get some pretty significant, hypertrophy and strength gains if I only use 20 to 30% of their 1 rep max with some of these different movements. Well, if you occlude blood flow, 100% of venous, of the venous system, and then, 80% of the arterial system in the legs, and it's around 50% in the arms, you can have some crazy gains. And so I feel like that really opens up a lot of opportunity to have some significant impact with strength and hypertrophy with a lot of our patients if we could, leverage this technology. So there's a wide application for this. There's some research going on right now with people that are in the ICU. And so there's several different mechanisms that occur. If you want to hear some of the details of that, the podcast that we've done on BFR, we've done 2 of them. So Johnny Owens was way back when, and then I did one with Kyle Kimbrell, and then Ben, 2 other instructors with Owens, and that one was within the past year. But they talk more about the science behind it. But there's several mechanisms that happen as a result of creating kind of that hypoxic environment from restricting blood flow. And it's very fascinating stuff. But the results are just crazy with some of these studies. So wide array of application. The science is solid. Let's see here. It's progressive too. That's the other thing I like. So you can start super easy. I know that's a concern for a lot of us is, are patients really going to buy into this? A lot of times that we see BFR, it's used, with athletes are just going all out. They've got the pain face on. The veins are popping out, from their forehead. But you can even start this with someone just laying in bed and that tourniquet basically just squeezing their leg. And that's okay. They may not get strength gains. They may not, get a lot of the benefits that they talk about, but that's a good place to start. And you can progressively expose them to that type of activity. Because that's what I was concerned about. I mean, it's not a pleasant thing. It can be somewhat painful. And so I was like, no one's going to want to do this. But there's a way to grade it, to have a great exposure with this activity that the patients are going to find to be helpful. So that brings up probably the question of, is it safe with our patients? And to the 2 questions that Zach asked us, or that we should think about our patients, was really helpful in framing this is, are they safe for exercise? All right, if they're safe for exercise, then they're probably safe to do BFR. But then secondly, are they safe for surgery? Because if they're in some type of surgery, especially that orthopedic surgery, some type of limb, surgery with the extremity, then they're probably going to have a tourniquet. So they've been deemed to be appropriate for long-term use of a tourniquet. I think 5 to 6 minutes of tourniquet use that's going to be much wider and safer in that manner. They should be fine with that. So are they safe for surgery? Are they safe for exercise? And with a lot of our patients, we would say yes. So they're probably safe for BFR. There are some general kind of precautions, contraindications. But what was just really cool is when I was thinking about the patients that I'm working with now, I could use this with a ton of them. There's maybe a couple people that just have some cardiac issues that I probably would not. But the majority of my caseload would benefit from this. So that was really encouraging. And another thing that Zach brought up was, how, we can put on our clinical hat and say, hello, Kenny, how you doing? That we can, just assess, we can do a trial treatment, assess their vitals, see how it felt, and then make an informed decision from there. So it's not like, once you go all in, there's no turning back. We can do a little bit at a time. It's okay. And then assess to see, how people tolerate that, which I found was really encouraging. So those are the big things. I would encourage y'all to check this stuff out. If, check out the course, but if not, just look at some of the research on this stuff. And we try to talk about it a good bit on our podcast, and we've done, 2 specific episodes on it. But I mean, right now, I don't want to be, jump on a bandwagon and, just go with the fads, especially with a lot of the different modalities that we've seen in rehab, that, they come, with full force, everyone buys into them, and then, they collect dust for the next, 10 to 20 years. I don't want to, think, I just don't want to jump on a bandwagon. But the evidence behind this stuff makes me believe that this is not just some trendy thing in therapy. This is something that is going to be a very, very valuable tool that we can continue to use in a lot of different situations, not just, the pro athletes that we're seeing, use this stuff on ESPN, but, the people that we work with. So I highly encourage you all to check it out. If I were to be honest with some of the critical feedback, it's a lot of information. So, I mean, we're talking, we probably reviewed or referenced over 70 research studies, and that's probably an understatement. So if you're completely new to blood flow restriction training, you sign up for one of these courses, definitely read the material going into it. They give you a good little handout, a solid, 120 some page PDF with tons of information. Brush yourself up on it. I wouldn't go into this blind. Be somewhat informed. That's going to make it a little easier to consume a lot of the big things. I definitely found myself trying to catch up, take notes, and it was overwhelming by the end of it. But if you do your work on the front end, you'll be fine. The piece of equipment can be expensive. I think $5,000. But you could potentially make your money back relatively quickly. I mean, it depends on how you use it. You can only use one cuff. Andrew, Chris, good evening. So you can only use one cuff with each machine. So that can be a drawback. If you want to do some type of bilateral work, you need 2 separate machines for that. Sorry, the game just went off. I want to see the Bucks lose. So that can be a drawback. And in a busy clinic, that can be an issue. With a lot of people were talking about that. But for me, the home health clinician, that's not a big deal. It's battery. You can plug into the wall. It's also battery operated. So it'll last about 2 hours of consistent use. So for me in home health, I'd probably be good for the day. So those are just some things to consider. We talked a lot about communication. How do we communicate this with our peers, with the physicians? Because a lot of it is going to be in tandem with some of the things that we're seeing from our physician colleagues. So that's where just a good, solid, in-service or conversation showing the data that we have for this stuff. And it's not just physical therapy data. These are physicians, physiologists that are studying this stuff. You can have a really good conversation and inform these people that, this stuff it can be super effective. So Andrew, I love that course. Andrew, I'm assuming you went to the Cincinnati course that was recent. I think Ben taught that one. But yeah, man, it's a good course. One day, jam-packed. I highly recommend it. I had a good time. My father-in-law went. That was cool. It was my first. He's a physical therapist. I'm going to have him on the podcast at some point. He's like a legend where I'm from in Huntington, West Virginia. And that was our first continuing ed together, which was kind of cool. Tali, I see your question. Did they talk about if there's risk if they're on anticoagulants or either hemodynamic or clotting abnormalities? So them being on an anticoagulant is in and of itself not necessarily a contraindication. So they'll do this with post-ops. The people that may still be on Lovenox, for example. So they'll still do it with those people. But if they do have if they've had clots, before in the recent past, then they're a little more hesitant. So they did bring that up. But what was interesting is he talked about some of the research on DVTs, and tourniquet use in and of itself is not necessarily, a risk factor per se for DVTs. There's all these different factors in terms of just overall health, activity levels, things of that nature that are kind of a bigger contributing factor than tourniquet use. But I think the cool thing that we need to remember is that when you do this, you're pumping it up, and they're typically underneath that pressure for 5 to 6 minutes, and you're doing different exercises with a little bit of rest in between, and then you deflate, and then you get the rush of blood back in and all the good stuff that comes with that, and then you may do another round as well. But it's not, we're not talking like 20-30 minutes of Therax where they're going to be occluded per se. It's only like 5 to 6 minutes at a time. Let's see. Yeah. In terms of the experience of it, that was painful. I did the straight leg raise. I was like the first one. Zach called me out, punk. And I'd never felt it before. And so, it feels like a blood pressure cuff. So it gets super tight, and you do around 30 reps initially. And what, the thought behind that was you're trying to make, a hypoxic environment. You're kind of, getting rid of any available oxygen. So you can make the sets more beneficial after that. So you do 30 straight leg raises. He threw a 2-pound ankle weight around my foot. I was like, what's this? Come on now. I do this with my patients. And then after rep 20, you're just like, all right, this is going to be tough. 30-second rest. We did 3 sets of 15 with 30 seconds of rest in between each set. And it progressively got more painful. If anyone's ever ran a 400-meter or 800-meter race, it was like that. I mean, just that lactic acid, just deep burn that you just want to stop. But as soon as you do stop, it goes away. So that's the good thing about that. But then after you do it, after the first time, it's not that bad. I just didn't know what to expect. The first time you're kind of ramped up, in terms of your expectations. And I'm sure my pain threshold was a little lower on the front end, but the second time it wasn't too bad. So, all right, that's all I got. I'm sure, I'll have more thoughts on that, but those are just some big things that I wanted to share with you all. Zach, we're going to do an interview here soon, and we'll get that up on the podcast. If you all have any questions about this stuff, post something in the Facebook group. Kyle Kimbrell is an instructor with Owens. He's in the group, active member. He'll answer any questions. But yeah, that's about it. You all have a lovely night, and I'll talk to you soon. And now my interview with Dr. Zach Dunkle, physical therapist and instructor with Owens Recovery Science. Well, Zach Dunkle, welcome to the Senior Rehab Podcast. It's good to talk with you, man.
Hey, Dustin. It's great to talk with you as well.
So you taught the BFR course that I went to in Lexington, Kentucky, and that was a special course for many reasons. But I mean, you're aware of this because we went to lunch. But my father-in-law was there, and that was the first continuing education course that we took together. So that was kind of a special moment that you were a part of.
Well, I'm glad I could share that moment with you.
Yeah, and listeners, we went to lunch with Zach and my father-in-law, Mark Taylor, who's a legendary PT around Huntington, West Virginia, and just had a really good conversation. So the listeners have heard or will hear a Facebook Live recap of the course, but just wanted to have Zach on to answer some specific questions from you all, the Senior Rehab Project Facebook members. So I fielded questions in that group. And this is what we have. But before we kind of dive into the questions, Zach, if you could just, give us a quick and dirty on what is BFR, blood flow restriction training, and then just walk us through how it's actually used in a session. Because I think people may hear about or see a clip on ESPN, but maybe not understand, all right, what is it? How much is this a part of the session? Just kind of the specifics of how y'all use it.
Yeah, so what we do is we use a specialized tourniquet device that allows us to occlude blood flow to a relative restriction to the individual. So we don't do an absolute occlusion. and we tailor that occlusion to individual characteristics of each person that we treat. And so from that, when someone comes in, we'll go through a standard warm-up, so to speak. We'll kind of get things going. The way that I use it in the clinic is from there, I will go about and do my manual treatment. That could include different things. It could include, joint mobilizations, let's just say, soft tissue work, dry needling, anything from that standpoint. And then when it comes to resistance exercise, we'll use the tourniquet. Especially initially early on, the majority of the resistance exercises that we do are done with BFR. As that individual progresses into the rehab program, I'll still incorporate BFR to some extent, but I shift them much more towards a higher load exercises and use the cuff or the tourniquet for their ancillary or accessory lifts. And then within the treatment, I'll conclude the treatment with balanced proprioceptive work. So I like to kind of finish and do balance at the end once they're fatigued, because I believe that we get a better balanced response and we train balance better that way.
Wow. So what is your clinical thought process behind BFR early on in rehab and then weaning them off as they're progressing?
Yeah. So a couple of the things is when someone comes to see us, any sort of PT, they typically have some sort of pain that drives them to see us. And so, what we know, we have the ACSM guidelines state that we have to load to a certain percentage to get a favorable muscle response. Well, the tricky thing that we have is someone who comes in with an acute injury or comes in post-surgically that may have surgical contraindications to loading. We need to still produce a favorable muscle response, and BFR allows us to do that. We can produce similar muscle changes at lifting at 75, 85% of what they maximally lift, but we can do that at 20 to 30%. So early on, whether it's I'm faced with surgical contraindications or simply they just don't tolerate load because they just tore a hamstring or they just injured themselves. And so I can use that low load that not only is low load to the muscle, but is low mechanical stress to the joints. And then as things start to recover and we work through that rehab program, the goal is always to get them back to high load training because the tissue has to tolerate that stress. And so I'll transition them into the main lifts or the kind of core lifts, if you will. Those will then become the high load lifts. And then I still may break out and do, let's just say, some isolated hip work. So if we see that someone has let's say a glute weakness, for a lower extremity, I'll train them with squats, and then we'll run the intensity up on the squat, and then I'll break out and do proximal hip strengthening with the cuff on. So it's kind of just a little bit more complete aspect of rehabbing someone and getting the tissue back to tolerating that high load.
Yeah. And I think that's a very important point that I definitely want to make sure the listeners get, that, the people preaching the BFR gospel are not claiming that, it's the end all, be all. It's the only thing that we need to do. That, it is a tool in our toolbox used in a specific time for a specific period. It's hard to replace some super heavy loads that we can do with some of these, functional movements. So that's a good point. I feel like it gets lost a lot when people, hear the BFR message or whatnot.
Yeah. I mean, and I think I always kind of joke around when I say it in the course, because I'm like, it probably sounds like pretty counterintuitive that here you have someone advocating this, but then tells you that we need to get away from it. But I think when you listen to, whether it's Johnny, Ben, Kyle, myself, any of the other guys out there teaching this stuff, is the goal is always to get back to high load training. And that is it may be different in different populations, but if you're talking and you're working in the orthopedic population and the sports medicine population, those guys need to be able to tolerate more than 20, 30% load. I mean, the tissue, the eccentric load that's required a lot of times is way more significant than even 80%. So we have to get pretty close to as high as we can.
Yeah. So if, I'm a home health PT, a lot of the people listening are, they're either home health or working in a skilled nursing facility, acute care, outpatient, several settings, but they have a specific interest in older adults. When I talk about BFR with other Jerry PT clinicians, safety is always, the first question, I feel. So if you are working with older adults, say, you have an eval coming in tomorrow, someone that's, let's say, 80s, mid 80s, something along those lines. I'm not going to give you a diagnosis or anything, but what is kind of your mental checklist, or what are you thinking about in terms of if that person is going to be a good candidate for BFR, or if that person is not going to be a good candidate for BFR?
Yeah. So a couple things, and this isn't like all inclusive, but very general. What I'll do is I'll say, this person coming in, are they able to have a surgery performed? So can they go into surgery? If they can, that means that they're going to be, the surgeon at least believes that they can tolerate a tourniquet. And so from that standpoint, then we say, is this person safe to exercise? If they're safe to exercise, then the third question is, can we exercise at a high load? So if we're safe to put a tourniquet on somebody surgically, we feel pretty confident that we're going to be safe putting a tourniquet on at a much lower pressure in rehab. And then if they're safe to exercise at a high intensity, we should be safe from that standpoint, from a cardiovascular standpoint, because what we see from cardiovascularly speaking, we do not see near the rise in blood pressure or heart rate that we get from high intensity loads. Some specific populations that I would not use the tourniquet with that jump out is if someone has uncontrolled hypertension. Hypertension needs to be managed. If it's managed with medication, then we're going to be safe to use the BFR with them. If someone has a recent history of a DVT, we're not going to use the cuff with them. If they have a tumor that's distal to the cuff, we're going to hold off. And then if they have a diagnosis of cancer and they're currently being treated for cancer, we're going to hold off from there. But that's pretty much the general guideline is, if we're safe to do surgery, and then if we can exercise at a high intensity, we should be pretty good. When it comes specifically to geriatrics or someone who comes in and they may be like, you may think and consider, well, this person really may not even tolerate exercise. There's no way that they're going to tolerate, something as intense or perceptually intense as BFR. I typically start them with something pretty easy. It could be bridges, just general table exercises. And then from there, we maybe just do one or two exercises the first time that we do BFR. And then from there, we just progress into a little bit more of an intense exercise, maybe a weight-bearing exercise, things along those lines. So, yeah,
that's a good point. Did you learn that lesson the hard way, or were you wise enough to realize that you should probably wean them or introduce them in a slow manner?
Yeah, it's something that I just have kind of noticed because, I remember when I took the course, the guy I work with, we were at the course together, and, just like you, Dustin, we start with straight leg raises when we introduce it. If no one or the folks listening haven't done BFR, straight leg raises becomes a pretty intense exercise. And so, one of the other guys in the group was like, he's like, hey man, like you don't have any weight on. And I was like, all right, go give me a cuff weight. Well, the guy I work with comes back with a 7.5 pound cuff weight. And I was like, dude, for real? And so, so you have that aspect. And I'm a pretty young, relatively active, fit.
You're fit.
Yeah. Yeah. So I was like, dude, this is pretty brutal, And then I had a guy, he was actually he was an older guy, pretty prominent ballet dancer. He danced in Paris and in New York City Ballet and whatnot. And he wanted to do BFR. So we were doing it with him. And he didn't even really tolerate it without any weight on. And that's when I realized that, some of these exercises you just need to kind of taper and slowly introduce, because the last thing I think knowing how powerful and how effective the treatment is, you really want them to understand it's beneficial, but yet it's a challenge, and you don't want to scare them off the first time you do it.
Yeah. 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 And I mean, you bring up lots of good points there. And I feel like the big thing is one of the most powerful lessons is people that are actually doing it or actually trying it. I mean, that was huge for me to do those straight leg raises, do the hip abduction, actually have that cuff on and experience it. And that will definitely, inform me, if I can ever get my hands on a unit to use with a patient, that I think I'll be in a better spot. So, that kind of brings me to the next point. So the financials, because, these units, Delphi makes them, and I think how much are they running now in terms of price?
It's around $5,000 for one unit. Yeah.
So $5,000 for one unit, and only one unit can use one cuff. I'm in the Owens Recovery Science Facebook group that all the students are in after you take the course. And there's some people doing some crazy stuff. I mean, we're talking backpacks with two, Delphi units that are, powering two cuffs on the thighs, and they're doing, different closed chain activities, squats, deadlifts, all kinds of different stuff. Now that's amazing. The results that they're getting are amazing, but the financials are always going to be a point of conversation with clinics. What tips do you have, or how do you try and present why $5,000 per unit is worth it for a clinic owner or a home health company or some of these people that are in those types of positions?
Yeah. So I think a couple things to think about and consider. If we go back to the very first question, is how do you implement this in a treatment plan? So let's take a couple populations out there. We'll say your geriatric population. You see those folks, whether it's home health or, in the clinic setting, you see these elderly Medicare folks. In the clinic I work in, we see about 33% or so of our population is on Medicare. And so along with Medicare comes the degenerative changes that just naturally occur. Let's say specifically knee arthritis, So we say one of the big things that maintains someone's function is quad strength. And quad strength is a pretty good predictor of outcomes with knee pain, and then even after a knee replacement. Mm-hmm. The tricky thing is ACSM guidelines say, we have to lift to say 75% load. Well, we have a study that was just published that showed with patellofemoral pain at a moderate intensity load, lifting at 70%, we can do low intensity 30% of load with BFR. And over 8 weeks, we have a 49% greater increase in muscle torque in the knee extensors than what we get out of the moderate intensity group. The other great thing out of that study, there was a 93% greater reduction in pain with ADLs in the group that did BFR exercise over the moderate intensity group. So now here we go in a clinical population. We take that and we say, so we have these ACSM guidelines, but what about for the individuals who cannot tolerate lifting at that load? So if you can't actually lift the load, it doesn't matter, theoretically, what we talk about the load that needs to be lifted. So if we can reduce the mechanical stress to the joint, we can have a much more favorable response to the muscle. And now if we talk about in the surgical situation, let's just say like coming off an ACL injury. So we know ACLs take a long time to recover, and there's various reasons for this. We have a study from 2003 that looked at, we're going to do rehab for 4 months. And what we see after that, and both groups are going to do the same rehab, except one is just going to do their rehab exercises with the cuff on, and the other group is going to do just free flow, low intensity therapeutic loads. And what we see is the strength in the knee extensors is significantly, it was about 9% off, depending on isokinetically how we measured that, compared to the group that did their low intensity therapeutic loads. They were like 33, 35% off still. So we're much closer at 4 months to baseline than what we are doing the same load. And we see another study that was a meniscectomy study. We had over 4 weeks, we had double the knee extensor torque in the BFR group that just did 3 additional exercises under occlusion. Than the group that did their free flow exercises. And so lastly, Dustin, that specifically goes to the geriatric population, we can take walking And so we have a few studies where we just walked for between 4 to 5 days a week, depending on the total duration. So, upwards of between 6 to 10 weeks. And what we actually see is we're able to put muscle size on the quad or in the thigh and in the lower leg simply from just walking. We can also significantly increase knee extensor and knee flexor strength from just walking at a low intensity with the cuffs on. So the real benefit, and when it comes to bringing this to a clinic perspective, we can draw in clientele now. So we can, through advertising marketing purposes, we can market this to a specific patient population, and it extends far beyond post-operative orthopedics. It's conservative management, and it goes to the into the geriatric population as well. And then from there, I can tell you down in Atlanta, the regenerative medicine guys, and this is pretty much true across different areas of the country as well, the regenerative medicine guys really like BFR. It seems to be pretty effective in how they manage patients as well, and it meshes very nicely. So I completely agree. It is it's a large upfront cost, but I'll tell you also, in the clinic that I work in, we bought our first unit after we went to the course. Within 3 months, we had another unit. So you quickly realize, you have patients that you're like, yeah, I don't know if I would really use it with them, but then you start to see the benefits from it. Yeah. And then those people will then talk to their friends, and it's word of mouth will just drive it.
Yeah. Yeah. And I think, I'm sure, you've got a pretty good perspective of this, but at the course, here in Lexington, there were a few athletic trainers there that were associated with a physician group, some of the big orthopods in town where I'm at, and just to see how even in those circles, some of these orthopedic surgeons that are doing, joint replacements or, different types of surgeries that we may see with our older adult population, they're coming across this stuff too. And I definitely see it as an asset to be, an early adopter, especially in the Jerry PT world, in terms of being able to, build, good relationships with some of our referral sources and just really, establish ourselves pretty well in the community as people that are doing some really, really cool, interesting, and effective therapy.
Yeah. Yeah, man, that's the thing too, is, with the geriatric population, one of the struggles that we have, and it's a natural part of aging, we lose muscle. And between 50 and 80, that rate of sarcopenia just significantly accelerates. And so, we need, and there's, reasons for that. But we need to find methods to help offset that, because, like the one slide in the presentation we talk about, when it comes to predictors of mortality, that meta-analysis that we referenced was a sample size of 2 million people. And the greatest predictor of mortality, it wasn't systolic blood pressure and high cholesterol. It was maintaining strength. And so, if we can and it was hand grip strength at that. So if we can maintain hand grip strength, that actually reduced the risk of mortality by 31%. So pretty significant factors, when we just look at maintaining function and maintaining muscle.
Yeah. Incredible stuff. So listeners, if you have any further questions about BFR or any questions about the course that Zach puts on or any of the other guys with Owens Recovery Sciences, hit him up. So Zach you're on Twitter, right? Do you know your handle off the top of your head?
Yeah, it's ZDunkPT, and that's the same awesome. For that's Instagram as well.
ZDunkPT on Twitter and Instagram. The website, I believe, is owensrecoveryscience.com.
It is, yes.
Okay, and so links to all that will be in the show notes. But yeah, ask questions. Hit him up on Twitter, Instagram. I know his counterpart, Kyle Kimbrell. Kyle's not as pretty as Zach is, but Kyle's in the Facebook group that is usually able to take questions related to BFR.
Dustin, I don't know what Kyle's deal is. He hates on us, on East Coast guys. I don't know what the deal is, because I don't know where he thinks he gets his bourbon from if it's not Kentucky.
He's jealous because we have hair. That's what it is.
That's exactly what it is. We have man beards and hair. That's exactly what it is.
Oh boy, I love it. All right, Zach, I appreciate your time and awesome course, man. I really, enjoyed myself, learned a ton. I know my father-in-law who, is typically skeptical of this kind of stuff, kind of the stuff that's new and flashy and people are talking about it. Cause he's seen fads come and go for decades. I mean, he's been a PT for, I think, over 35 years. And I mean, even he was, really interested in this stuff, and I believe they're working on getting a unit. So awesome course. And I appreciate your time, man.
Absolutely, Dustin. Thank you.
Right. Hit me. Thank you for listening to the Senior Rehab Podcast. If you only listen to these podcast episodes, you are missing out on 90% of the Senior Rehab Project. Hop on over to seniorrehabproject.com where you can join the movement that's advancing care for older adults. You can join for free or become a part of the Game Changers where you can get some free gear and access to our monthly meetup. Just go to seniorrehabproject.com. I appreciate y'all, and I'll talk with you soon. But in the meantime, do not forget to stay funky.